I think one of the things that we've learned in our continuous quality improvement is not to spend a whole bunch of time reading the bios because they are available to you in other settings. I will just note that I think folks who have already been at some of the other sessions this morning know that Megan has been with Team Up since its inception, originally created and implemented the research, kind of the evaluation arm of Team Up, and led that research probably 3 or 4 years ago, began to co-direct with Dr. Chris Sheldrick at the end there. And recently, Megan became the first chief scientific officer at Boston Medical Center for the health system. So it is our pleasure and honor that she continues to be involved in Team Up in an advisory capacity around the evaluation. So with that, I will pass over the baton.
Thank you. And anything that I can do to make Anita's life easier is a really good thing. So I'm glad that I am able to do that. So welcome to this session. I think it's a really important one because what we are going to focus on from the data perspective, from the clinical perspective, is thinking about equitable access to Team Up to behavioral health care through the lens of data, through the lens of our clinicians. And, I think going back when we started the initiative, Team Up has always been about health equity. Health equity has always really been at the core of the model. And yet I think we kind of moved through it. We were measuring screening rates, we were measuring warm handoffs, but we weren't looking deeply within health centers and in the data to see if there were differences based on populations. And then, I think a few things happened. I think one, the pandemic happened really early in the start of cohort 2. And while, I don't need to say this to this group, while COVID was devastating for everybody, it disproportionately impacts structurally marginalized communities in the communities that our health centers served and saw every day. As Anita has said, when I think about COVID and COVID for kids, it was a mental health crisis, and it continues to be a mental health crisis for those kids who lost time in school, lost time with peers, and again, had disproportionate impact on structurally marginalized communities. At the same time of COVID, there was a murder of George Floyd. I think really important conversations about race started to happen. And so we similarly said, we're not actually collecting the data that we need to be collecting to look at this. And we want to really think about it in a way that is meaningful, to move away, as Chris will talk about, from these cookie cutter definitions that people have about race and ethnicity, and try to do it in a way that's meaningful for the delivery of care. So I think it's going to be a really interesting panel, an important one. I will say the work really takes a village. In addition to always deep thanks to the Smith Family Foundation, the Klarman Family Foundation. There's been work in integrated behavioral health across BMC. We are thankful to the Yockey Foundation that funded the child and adolescent psychiatry's move to a new space, which is really beautiful and it's adjacent to our pediatrics clinic. HRSA, the Health Resources and Services Administration, has really supported workforce training for behavioral health clinicians. And there's an anonymous funder that has helped to support Brockton's Behavioral Health Center and really meet unmet needs for psychiatric care. So we do this all together. We need to continue to do this work together. So with that, I'm going to open up. We're going to do a little bit of back and forth between discussion and presentation here, but really want to start. I will say I should actually tell you who's on the panel. I won't go into as Anita said, everybody's bios, but we have Rosa, who is the lead clinician for pediatric behavioral health and manager of 2 additional grants at Brockton. We have Dr. Nguyen, who is the Team Up clinical champion at DotHouse, previously was DotHouse's chief medical officer. Jess Rosenberg, who has been a senior data analyst for Team Up, really pretty much, I think, since it started, Jess. And Chris Sheldrick, now the director of Team Up. So Doi and Kira, would love to hear, maybe we'll start with you, Kira, just about the population of kids and families that you serve in your health center.
Sure. So at Brockton neighborhood, we have a very diverse population. 68% of our population is non-English speakers or English as a second language speakers. 58% are identify as Black or African American, 15% Hispanic or Latino. Of that 15%, 8 also identify as white and 3 identify as Black. Most of our population is Cape Verdean, Haitian, Brazilian, and then South American of some sort. So a lot of our care really involves language barriers. We have a really good team for interpreters, which is so necessary for the work that we do. And our clinicians and CHWs represent our population pretty well.
Hi, my name is Nguyen. I'm one of the pediatricians at DotHouse. DotHouse Health, formerly called Dorchester House, is located in the Fields Corner section of the Dorchester neighborhood of Boston. Our 20,000 patients that we see, unique patients that we see a year, include 6,000 patients who are in the Team Up population, so under age 19. Of those 6,000 patients, about a third, a little bit more than a third, identify as Asian. A third identify as Black, African American, and the final third is pretty much split Latino, Hispanic, and white Caucasian. The great majority of our patients are low income. 90% of our patients live below 200% of the federal poverty line. So 2% of FPL in 2023, if you're wondering, was just under 50,000 for a family of 3 per year. Most of our patients come from our surrounding neighborhoods. So 75% come from the Dorchester, Roxbury, Mattapan, Hyde Park neighborhoods. And we have patients who come from Quincy and Randolph as well, part of families moving out of Dorchester and a little bit farther into the suburbs. The majority of our patients speak a language other than English, or rather prefer to receive their healthcare in a language other than English. And the top languages that are spoken at DotHouse are English, Vietnamese, Spanish, and Cape Verdean Creole.
Thank you. And as you both work with families, work with patients, Kira, you spoke a little bit about language and language difference. Could you, talk to folks about like where you see their particular barriers to accessing healthcare, to accessing and engaging with mental health from the patients and families you've worked with?
Sure. One of the biggest things, and I think we all know this, is with our immigrant population, a lot of them don't currently have status. So they have what we call CMSP or Mass Health Limited, which obviously narrows their ability to get healthcare outside of the health centers. And that's especially true for mental health care. The language barriers, even if they do have standard insurance or private insurance, that also limits them a lot of places, even though they might have phone interpreters or something like that. It doesn't necessarily give them the access that we think it does. Listening to someone over a phone interpret is not the same as having someone right in front of you. The other, there's a lot of barriers around getting specialty care when you don't have the insurance for it, and language capacity once again becomes another issue. I also like to point out that, a lot of people who are in more privileged situations have access to complementary care that our low SES patients do not. So things that we may or may not take for granted, just for example, acupuncture, things like that, they do not have that kind of access. Specialty mental health care, so like EMDR and things like that, that are, you know, you go to specific people, they don't have as good access. Luckily, at Brockton neighborhood, we do have people who are trained in some of these. So our population has some access to some complementary care. And then with our population, the other barrier is psychoeducation itself. So a lot of our patients either like to keep any problems like that within their family. They don't want to bring the community in. They don't want to talk to health professionals about mental health. Some don't believe mental health exists. Some, due to their religious beliefs, think that all of those things should be handled within the church or their religious organizations. The other big issue we run into is the barrier between the children that we serve and their parents, who have very different upbringing. So their parents may have been raised in Haiti or Cape Verde, whereas now they're raising their children here in the US. There's a huge divide between what they believe mental health is. The kids are much more, I'm depressed, and they'll say that. And the parents, you know, for example, I had a kid from Haiti whose mom said, I don't understand why she's saying she's depressed. She has everything she needs. And, you know, I think she just needs to go to church more. And the kid is saying, no, I have depression. So it's not that the mom doesn't care. It's that the mom believes and has been taught one way of how to deal with something and how things should go. So we're also that bridge in between the two that, you know, that can be a barrier. Some places won't be that bridge. We'll just go, well, either that mom isn't taking care of their kid or the kid needs to pay more attention to their mom. So that in a nutshell is some of the barriers that our population has.
What about you?
Yeah. So, you know, I'm fortunate to work as a pediatrician at a health center that actually started as a settlement home. So way before the 1960s and 70s and the community health center movement, DotHouse back then, Dorchester House, was a settlement home, and its purpose or mission was to provide human services for new immigrants. So that tradition, thanks to leadership, has been continued onward, and we have a budgetary commitment to continue to fund staff who help with material needs or social determinants of health, like transportation, housing. So really fortunate to have to be working in an organization like DotHouse. As Kira talked about, you know, working with diverse families and communities, there are often challenges that we don't even imagine. So I think lots of us can understand the challenges of working two jobs or speaking language other than your healthcare provider. But there are other challenges too that sometimes I'm surprised I didn't think of. So one example is, you know, I remember when I think about cultural differences, understanding of health, I recall when I was in med school and I had to read When the Spirit Catches You and You Fall Down, which I think is familiar to many people as an example of how patients from different cultures can have different understandings of health symptoms, but sometimes the differences are just even more fundamental than that. So I had several families who had a 2-year-old, and the 2-year-old was not talking at all. And I was obviously very concerned. We had been talking about this from, I don't know, 9 months through 2 years. And I felt the weight of what I knew to try to get the kiddo into early intervention services ASAP. They run out at 3, then they have to get into the school system. So all the logistical concerns in my head. And, you know, the parents said to me and the grandparents said to me, you know, we're just not worried about it. We don't think that they need to talk until 2. And similarly with other developmental milestones, we talk about, you know, self-feeding when kids feed themselves. And some families believe that, you know, parents should be the primary feeders of their kids and spoon feed them through age 2. So there's some fundamental differences in how sometimes our families understand development, understand health. And as much as you try to read up on things, I think, you know, what's been helpful for me, and I know for a lot of my colleagues, is just to approach the situation with a lot of cultural humility and just to ask questions, because even if you speak Vietnamese, I speak some Vietnamese and some Spanish as well. It doesn't mean you'll be able to understand the situation for the family or their everyday beliefs and practices.
Thank you. And maybe to build on that, Lee, you talk about cultural humility. Are there other either ways of being present, things within pediatrics that you have done, and then maybe afterwards you, Kira, that you have really felt like met the needs of families coming from many different backgrounds to help enhance access?
Let me this one first. Yeah. Yeah, I guess some of it is, operational design principles. So, one of the things I happen to have had the privilege of serving as CMO during our COVID response at DotHouse. And one of the things that was very clear to me then and to our team then, as we were looking at the differences in receipt of, let's say, vaccines and COVID testing when we offered it to the community among patients of different backgrounds, is that operational complexity that we often build into our systems because they're necessary for efficiency, operational efficiency, really create obstacles that are very hard for underrepresented or underserved communities and families. Example is having different hours for clinics at different days of the week. And so if you are a family that, is not going to go online and look to see if the clinic is open, you're going to show up and the door is going to be closed for that particular service. So as we built workflows for, ADHD, for depression evaluation and initial treatment in primary care, we really thought about, how can we make the door larger? How can we have a single door for families to pass through? How can we, if there's a challenge, put the onus on us rather than on the patient? So rather than a workflow that has a very strict sequence of steps that families have to go through to get to the final service, having some redundancy in that workflow so that if one part of it is missing, the patient will still get the service. Years ago at DotHouse, and I think this is the case for many other places as well, because certain services like psychiatry were so treasured, and there's so few appointments. We used to say that patients really needed to have a joint behavioral health therapist appointment as well to, get into that psychiatry service. And it wasn't to make it difficult for patients, but it was to, one, make the psychiatry visit more useful because now the psychiatrist has a lot more information that was gathered in the therapy appointment, but also to give a better chance that patients would show up for that medication visit. So there was reasons for it that all make sense, but it's really hard for patients if they miss that first appointment to not have access then to another effective treatment for their mental illness. And so as we thought about this, we thought, let's not put up barriers, even though we do want to have well-defined team roles, some fidelity to our workflow and our model and our swim lanes. How can we make it as patient-centered as possible? And sometimes that comes at a cost to us. Sometimes it's just inconvenient, but we have to build in that flexibility.
Thank you. Kira, how about for you?
Well, I'm going to let you into my little secret.
Only in this room.
Yes, only this can't leave. The interpreters and the CHWs and the patients that I work with, I learn more from them than I think they ever will from me. And if you don't utilize the supports around you as a therapist, as a BHC, even probably as a PCP, then you're really missing out on a huge portion of connecting with your patients. There are many times when I have sat with interpreters and a patient and I've said something, an interpreter has said, that is not going to translate right. I need to let me explain why, because I wouldn't know culturally how that's going to come across. And same thing with CHWs there, as a white person in a health center, I don't necessarily know all of the cultural differences. And having them there to teach me what is going to be helpful for a family is so important. So that is one of my secrets. The other is I don't believe we should ever assume ignorance or malicious intent where it could be that their knowledge is different than ours. So sometimes people will see a family of immigrants come in and the family will use corporal punishment, right? And that's one of the number one things that we see a lot. And it's not ignorance and it's not malicious. It's their knowledge of how to raise kids. And that's different knowledge than us. And it doesn't make it bad. So we talk to them about like here, you know, we have different ideas, different ways, and we would like to share them with you. And we can connect on that level rather than me assuming you're abusing your kid. And that, you know, goes for many different things. That was just one example that comes up often, but I never assume that there's malicious or ignorance in a person that has different knowledge than me.
Thank you. I think that's a really nice segue. I'm going to turn the podium over to Chris, because I think when you look at the federal government, UDS, the way people report data about patient populations, one is forced into these very prescribed like check boxes. Somebody is this or is this, and I don't think they actually well match the complexity of language and ethnicity and race. And so part of what Jess and Chris have been trying to do is think about, are there ways to think about this more expansively or differently? So I will turn it over to him.
Sorry, one hot second. I gotta make sure that Chris can move the slides.
We can see my slides.
Oh, let's try this. Yeah, all right.
There we
all set.
go.
So
Okay.
this is what we need.
Great, that beautiful. Thank you. We really wanted to begin the talk today with these kinds of stories for exactly the reason that Megan said, just to kind of really convey the depth and the richness of what's going on here, and to then think about data in that context, and really to think through, what is the power of these data? Like where do the strengths lie, but also what are the limitations in the data, and how do we account for both in terms of really using them to try to advance equity? So I'll begin by showing you a big black slide, because maybe I hit the wrong button. Nita's gonna bet I did hit the wrong button. Wait, oh, I fixed it.
Perfect.
Okay, nothing to disclose. The black slide said it all. Okay. This is one of many slides I could have shown, but this has been a long conversation. We've known this for a long time. 2002, there was a landmark report by what was then the Institute of Medicine. It's now the National Academies of Science, Engineering, and Medicine. Basically documenting all the many kinds of disparities that exist in healthcare in the United States. And of course, they could do that because there have been decades of research already on that kind of thing. So this is a very long and old story. Now, since that report, every year, AHRQ, or the Agency for Healthcare Research and Quality, has published a report on disparities in the US and kind of how we're doing, all the progress. And they're going to have a long career doing this, because there's never a lack of disparities in US healthcare. Like basically, I think the consensus is if there's areas of progress, they tend to be very localized. They don't generalize well, and these things really persist in U.S. healthcare. So in that context, one of the themes that I think has been emphasized today is that Team Up was really co-created with federally qualified health centers. And this is a quote that we put in our report that I found striking when I read it. But when I'll tell you a little story. When we went to submit these papers to journals, they were reviewed by other researchers, in particular other pediatric researchers. And not all pediatric researchers are super familiar with FQHCs and the work that they do. So we had to explain a little bit. So that's kind of the context for this sort of line being in there. But nationally, FQHCs provide care for 1 in 11 Americans, including 1 in 7 of Black race, 1 in 6 of Latinx ethnicity, and 1 in 2 living in poverty each year. So FQHCs are really at the forefront of caring for many of the people in our country who have some of the highest healthcare needs, and are really at the forefront of addressing equity and advancing equity here. So co-creating Team Up with FQHCs was really critical to the original mission of the initiative. But serving the diverse populations directly is not enough. We also want to ensure that we're providing equitable care at the highest quality to all patients. So I think one of the things that you heard is that at different federally qualified health centers, they serve different distinct patient populations. I heard about Vietnamese populations, Cape Verdean populations, Haitian populations, populations that were born in the US. They differ by language, they differ by race, they differ by ethnicity, they differ by income, they differ in all kinds of different ways. And we want to make sure that we're providing the best care we can to everybody at the same time. So this is going to be a little talk about data. And I'm a little shocked because throughout the day, people keep talking about data, and it's like in positive tones. Usually it's like eyes glazing over. This is like with my kids, or, I try to bring this up at like barbecues. I don't get the same kind of result, but it's about analyzing data.
Secretary Fetters did talk about the data books, which I actually owned. I got very excited about.
I know.
There was a reference to the nerdy data.
So I want to talk a little bit about how can our thinking is currently about how we can use data to really advance equity and really think through these questions and all the complexity. And I'll say that there's at least 2 other things that we really want to be thinking about when we're analyzing the data. One is, how do we understand the results? Analyzing the data is one thing, understanding the results is another thing. And I think understanding the results is partly based on the data, but partly based on the kind of stories that you just heard. So we'll talk a little bit more about that. And finally, it's great to understand results. Like, I'm an academic researcher, I just want to understand everything, right? But is that really enough? Really, I think what we want to be doing is improving care. And these decisions about making plans to improve care really go above and beyond that the understanding of results. Like, I think of the example that we just gave about having different hours on different days serving as an impediment to care for some patients. That's not going to show up in my data set, right? But that might well be part of a plan to actually address a barrier that does show up in some way in the data set, right? So we need to be able to think these things through collaboratively. So, what are the resources that we do have? Well, and by the way, plans to improve care ideally comes back to more analyzing data to really see how we're doing along the way. What we have are really rich data from electronic medical records from the sites. And here we're very fortunate, again, to have the funding from our funders to be able to get these kinds of data, partnerships from the FQHCs and all these people called SQL coders who actually help provide us with the data on a very regular basis. People like Jess, who have devoted big parts of her life to combing through the data and cleaning them and making sure that they're accurate and that we haven't messed something up in some way. And because of that, we're able to look at the data that are available in those records on patients' race and ethnicity and language. Now, again, we don't have all of the data. We're never going to have all the data that we want, right? But we have the data that we have, and we can try to understand what we can based on these sorts of things like race, ethnicity, and language. Maybe we would also like to know things about religion or country of origin or whatever. But if we do, we're going to have to infer it from what we have. And secondly, obviously, what electronic medical records are really designed for is to provide data on healthcare services. So with these two things, ideally, we use the acronym REL for race, ethnicity, and language. We can look at the relationship of REL and find differences in healthcare. So that's the kind of crux of the data analysis part. But as the framework suggests, like that data analysis part may be well and good. It can sit there in the computer and find all these little things called p-values, or the stats kind of pop out and you can see different things. But it's a different thing to really understand results and to improve care. And for that, what we really emphasize is dialogue with the FQHCs to try to figure out what these findings actually mean. I'll mention too that part of that dialogue, this is not just about the evaluation team. It's not just about analyzing data. All of Team Up has really embraced this. So we're fortunate to have been really moved forward with this data analysis initiative at a time when there already had been a lot of training and implicit bias and cultural sensitivity, and where this had really been embraced by our implementation team and by the sites. So the conversations are happening in that context. So going back to the data analysis though, because that's why we're here. We're all excited about data analysis. Questions arise when you're trying to analyze these data. So for example, okay, we want to look at differences in healthcare, but what differences? Like which services, which outcomes? There's lots of them, right? There's lots of diagnoses. There's lots of different kinds of services. There's lots of things that could differ between one group and another. Which ones do we want to look at? Do we want to look at all of them? That's a lot. Or do we want to focus on some that are important? Decisions need to be made. Also, what categories of race, ethnicity, and language? How do we want to do that? There's a lot of data there. So how can we approach this going along? So I'll talk a little bit about that. So as Megan mentioned, this is kind of one option that you see pretty commonly if you look around on the web or if you look in the research literature. And this example comes from the Uniform Data System, which all federally qualified health centers have to contribute to. So when they report out characteristics of their population, it typically looks like this, right? And this is the kind of thing you see. So there'll be percentages and numbers of patients who report Hispanic or Latino ethnicity or not, or the percentage who report Asian race or Native American race or Black race or white race, that kind of thing. So you get this kind of table with this different chart. So, one thing to start with is to just sort of ask ourselves, is this enough? Because this is the kind of thing that for me as a researcher or as a data analyst, this is the kind of thing that I've probably been trained to do and I would do very reflexively. But does it reflect the kind of stories of what we're hearing about the patient populations that actually exist at these different sites? So judgments need to be made. And, I put in this slide just to make the point that there's a lot of talk about evidence-based medicine, and evidence-based medicine is like a thing. It comes in quotes, it gets capitalized. It's been around for a few decades now. It's a movement within medicine to really use evidence better. And there's kind of two views on it. One view is that really we should be making decisions based on the evidence. And people will say that. That's why it's evidence-based medicine. Now, but there's a slightly more nuanced view that I think is worth emphasizing. And it's the view that we should absolutely be using the best available evidence to make our decisions, of course, but that it's not possible to use that evidence unless we also apply clinical judgment and expertise and patients' values and preferences. Like we need to have all of these voices to put things in context and actually really be able to make informed decisions. So there's this famous commentary that was published many years ago, I guess back in 1996. And it says that evidence-based medicine is not cookbook medicine. This is by one of the founders of the field. It's about integrating individual clinical expertise and the best external evidence. So I say that now because that's a theme of how we're thinking about these data. It's not just about like running our little t-tests and regression analyses. It's about doing those and trying to do those very well, but also having conversations about what they mean and what to do about them. So I'll try to be a little bit more specific about some challenges and solutions. So one of the challenges that this is like inside view on data analysis. One of the things that we have to deal with all the time is multiple testing. Multiple testing may not seem terrifying to you, but multiple testing is terrifying to me. Why would multiple testing be terrifying? Multiple testing is terrifying because the more tests you do, the more likely you are to make mistakes, right? Like think of yourself being a student back in high school. Is multiple testing terrifying? Yes, it is. Do you want to quiz every day? Yeah, absolutely. No, you don't want to quiz every day because eventually you're going to screw up and you're going to get a nap, and you don't want too many tests, right? It creates the chance for error. It also creates a lot of complexity. So ideally, there's like one really good test, not 100 sort of flawed tests. Multiple testing can definitely be a problem. So this comes up, first of all, in terms of this question of like, who do we compare to whom? And a standard thing you will see in the literature, if you look, is comparisons like this, where they take all the patients who are white and non-Hispanic, and they compare them to everyone else. And you see this all the time. And then they'll publish and say that there's evidence of health disparities. So why would they do this? Whoops. They would do this for a bunch of reasons. One is it's kind of easy. Secondly, it does have the advantage of just being one test. It's simple to understand. There's only one chance of making a mistake if you do this. You probably get big, good sample sizes. But it's also kind of problematic if you think about it, right? It does a lot of things that are problems. One is it definitely centers the experience of a group of people who look a lot like me, who have been traditionally centered in a lot of these analyses, and we should be really kind of thoughtful about that. And secondly, it completely obscures all of the kinds of nuanced differences that we're talking about in this everyone else group. So this is kind of a highly problematic thing that we're trying to get away from. Thank you. Okay, so if you're, alive these days and thinking about equity, the term intersectionality comes up. So let's talk about the opposite extreme. So intersectionality refers to the interconnected nature of social categorizations like race, class, and gender as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. So I think this is a really, really important theme, obviously, in terms of thinking about equity, right? Now, like I said, we don't have all the data that we'd like, but we have data on race, we have data on ethnicity, we have data on language. One of the things we kind of recognized along the way is we have data on place. And these, like, the meaning of race can differ from clinic to clinic, right? So an Asian population at one clinic might be very likely to be Vietnamese speaking, whereas an Asian population at another clinic might be very likely to be Cantonese speaking or of a very different ethnicity, right? So there's information in that place-based context and data as well that can be really, really useful. So intersectionality, I think, is a powerful concept to be thinking about when we're doing this. However, statistically, it can also be a little terrifying, right? Because there's a lot of variables and there's a lot of differences. And so if we think about multiple testing, it can create challenges to the data analysis. So let me kind of explain what I mean. So this is, not something that gets used in our clinics, don't worry, but I kind of pulled it off the web. This is a kind of common questionnaire that you might see if you're asked to report on like your own race or that sort of thing, or your own ethnicity. And basically it's a check all that apply kind of thing. So, you could check that you're Asian or Pacific Islander on a questionnaire like this or not. So that's two possibilities right there. You could check off that you're Black or African American or not. And that's another two possibilities. You could check off that you're Hispanic or Latino or not. And that's another two possibilities, and so on and so forth. We're starting to get a lot of possibilities. Just to be sure that we're really, really clear about the math, well, let's just look at the first three alone. For the first three alone, you could endorse all three, and some people do. That's the way this works. You could endorse just two, and there's actually three different ways of doing that. You could endorse just one, and there's three different ways of doing that. Or you could endorse none of them at all, and there's only one way of doing that. That's a lot of possibilities, right? That's 2 times 2 times 2. I told you this is going to be about data, right? So there's math. So that's in the three options, first options alone, there's already 8 possibilities. So now if I'm doing statistical comparisons, let's just say I decide to center one group and do comparisons, that's 7 different comparisons to that, right? But that's just the first 3 categories. There's more categories. In team up data, we have 7 categories of race, 1 category of ethnicity, and 8 categories of language. So for those of you who can't do 2 to the 16th power in your head really quickly, and I'm among them, I haven't got it memorized that's 65,536 possibilities. So I could make a 65,535 page report of all of the comparisons to one single group, and that's just to one single group. Do you see what I mean? It gets complicated really, really, really fast. Now, in practice, we don't have people who are actually in all these categories. In Team Up, we actually see 121 actual combinations of all these kinds of data, but that's 121. So that would be at least 120 comparisons. So it's a lot of opportunities to go wrong. Does that make sense? Is multiple testing seeming a little terrifying now? Imagine being anyway. No, you're not to you. So, and that's a good point. I see, and maybe you're a little bit joking, but maybe you're a little bit serious. There's a judgment call here, right? And there might be a time to really delve in deeply and look at it in detail, and other times to look at it at a more global view. And there's pros and cons to each. There's trade-offs here. And that's, whenever there's trade-offs, it's a judgment call. It's an opportunity for engagement with patients, with clinicians to try to make these judgment calls. And that's what this is kind of all about. So the way we're doing it right now is we're doing two things, and I'll show you the first one. One is, and I was one of the authors of this chart, so I'll describe this as a uniquely simple chart and tool. I'm maybe the only one to see it that way, but that's okay. But what we do is for each site is we provide a table that shows across very detailed information on the intersection of race, ethnicity, and language, and what proportion of patients fall in each one. So people get a kind of an overview of their own patient population. And then our analysts work with clinicians at each site to decide how do we want to divide this up. Like, if you want to identify your Haitian Creole population, or if you want to identify your Vietnamese population, what do you think they would look like in these data, right? Like, we don't necessarily have the exact data that we want, but how would that be reflected? And, is there more than one way we would like to run these analyses? So this allows us to actually make comparisons about what we think are clinically meaningful patient populations. So I'll say that's one way. The second way is in the background, we take this and we also run what are called sensitivity analyses, which is we basically also run the analyses a bunch of different ways to make sure we're not missing something important along the way. But this is our first step toward trying to get clinically meaningful information that can be understandable and actionable by the actual sites. And I'll mention too that we're not alone in thinking more deeply about this. There was a report from the Federal Reserve Bank of Boston called The Color of Wealth in Boston a few years ago that talked about reactions to the 2008 financial crisis. And basically they found big differences by different intersections of race and ethnicity. Like, not all Asian populations, not all Black populations fared equally in that crisis. They had differential responses depending on how their own histories, their own economic situations, how they were situated in Boston, what the kind of opportunities, what the challenges were. And very recently, this was just in August, there was an article in the Boston Globe about the state trying to do similar things, in other words, moving beyond traditional categories of race and ethnicity in terms of thinking about these data. I'll just mention that there's this problem of multiple testing. There's similar challenges on the outcome end. Like, we're looking for differences in what? Depression, anxiety, ADHD, autism, combinations of these. Services for these things, screening, diagnosis, navigation, therapy, medications, between different providers. There's lots and lots of things we want to see differences in. And this gets these reports can get very, very long. There's a lot of little pieces to move around. So how do we prioritize these? How do we think about this moving forward? So what we're doing for starters is, luckily, this happens in the context of ongoing quality improvement. So we go back to our quality improvement reports and see, well, first of all, what outcomes have we already prioritized? And once again, come back. This is a judgment call. Talk to the FQHCs, talk to the clinicians, and see what additional outcomes should we really be thinking about and be looking at that come from these stories. What do you think would be different? Like, one clear example that comes up is, since language is such an issue here, thinking about the translations of a lot of our materials, including the screeners, like, are these translations really equivalent? What about differences in literacy between populations? Like, these are the sorts of things that come up. I'll mention a few things about then, okay, we've chosen the groups, we've chosen the outcomes, we run the stats, the data are analyzed, we think we're done, but we're not even close to done because we still need to understand the results. So this is just a completely fictional example, but consider this for a second. In population A, 4% of kids are diagnosed with ADHD, and in population B, 6% of kids are diagnosed with ADHD. We have a difference. You know, there's some kind of disparity. How do we understand this? What does this mean? Let alone what do we do about it? But what does it mean? Well, it could mean a lot of different things. So one of the themes that we need to think about is, first of all, the data analyses are not perfect for a variety of reasons. One is that the data themselves are not perfect, right? Maybe the patients in population A or B were misclassified, right? The data on race, ethnicity, and language in the EMRs is by no means perfect. You know, there's not a lot of resources that are available to make sure that these data are accurate. So they're as accurate as they can be, but they're clearly flawed in some way. Same thing on outcomes. Like, what about having a child diagnosed with ADHD? Does that mean they necessarily have ADHD? What about a child not diagnosed with ADHD? Does that mean they definitely don't have ADHD? Well, there could be different reasons, right? It could be that they actually have a lower rate in one population than the other. It could be that they're less likely to be recognized by their parents. Their parents maybe feel stigma about ADHD and don't want it. Or it could be that there's a real barrier, like everyone in the family thinks that the kid has a problem, but they actually can't get the care to get the diagnosis. These are all very different reasons for seeing the same difference, right? For really understanding what that kind of thing means. You know, one of the questions I think about is, like, what does your EMR say about you? Does it match how you think of yourself? It might in some ways, it might not in other ways, but it's certainly not a perfect reflection of our overall healthcare experience. There's also things called type 1 versus type 2 errors. So, you know, for example, maybe population A and B differed, but just by random chance. And maybe if we looked again later, that difference will have disappeared. This happens all the time in statistics, right? I mean, to some extent, these things are a little bit of a roll in the dice, and we need to find what's persistent. Maybe some outcomes where we didn't find a difference really do differ, again, for random reasons. So this kind of error is why we have statistics in the first place, is to try to sort these things out, but it's never perfect. It's always probabilistic. Next, you know, a statistically significant difference, even if we're convinced that there is a real difference, is it clinically significant? Does it really mean something important that we want to pay attention to? We need to ask ourselves, you know, does this difference matter, and why does it matter? So is a 2% difference in ADHD big or little? It's a judgment call, and you may have an opinion, but who knows? And finally, you know, disparities, do they necessarily mean there's an inequity? And again, I think this speaks to understanding what it means. Thinking about the example I just gave, well, there could be a real difference between the two populations. Like, maybe one population is just healthier than the other, like their kids are less likely to have ADHD. Maybe it's that the families are less likely to acknowledge it, or maybe it's a problem with the healthcare system. These have three very different meanings to explain the same disparity with respect to whether or not it is an inequity. And that's going to also speak to the kind of response that we have to. So, you know, our solution to all of this is, once again, what I would describe as and I think you'll agree, a very simple chart. And I say that a little jokingly, but I haven't met anyone else who looks at this chart and thinks it's simple, but it does speak to the complexity of these questions, that this, I do believe, is the simplest chart that can be made that actually gives you the kind of information that you'd want for addressing these sorts of questions, even about a single outcome. This is a very simplified view of everything I've talked about, and it certainly could have been done differently. So, you know, one thing it does is it compares for a given outcome. In this case, it's about the percentage of kids who screen positive on a given screener. It compares every FQHC to the team up average. So those boxes, the 4 different boxes, each represent an FQHC. And you'd ask, why a box? Well, it's because, well, the site has an average screening rate or an average screen positive rate, but those averages actually have a statistical range. And so the box actually represents that range. So there's information here about the uncertainty, but it also ideally allows us and clinicians to see how their site is comparing to other sites. I need to stop doing that. Anyway, sorry. The second thing that it does is those little lines, is that it helps at each FQHC to compare each population within the clinic to the average patient at that clinic. So, you know, you can see along the bottom some of the groups that we decided to highlight here, but like we have an English speaking group, a Spanish speaking group, a Haitian Creole group, a Cape Verdean group, and a Portuguese group, all within one clinic. We can compare one group to another and see how they're faring. Does that make sense? So super simple chart, sort of, but there's one for every outcome. This is just 6 outcomes. We can go for many, many, many more outcomes and try to put it all together and to try to get an overall picture of what's happening. So once again, this is about really having dialogue with the sites. And so far, what we've done are initial rounds where we try to identify these patient populations, look at differences for a first level of outcomes, meet with the sites, have these discussions, get questions back from the sites, and then do another round of data analyses to really try to understand those questions and address those questions. So to end, I'll just say that, again, recognizing disparities is a first step. Understanding them is really a first step. Deciding what to do is even harder. So all of this is really about finding differences and trying to understand them. And I think that's about the limit of these data analysis. We can also monitor things over time, but what to do about it at the sites themselves has to come through with dialogue. And I'll mention that to advance equity, FQHCs really can just improve care for everyone. Like as I've said, my colleagues at the FQHCs can advance equity by showing up for work in the morning, right? They're serving populations of patients who have lots of needs, right? So just the mission of the FQHCs themselves is all about equity. But they can also choose to address the specific needs of certain populations within their clinic if they see this disparity. So, you know, that's a choice right there. They can also focus on one aspect of care, like they could really just decide to focus on ADHD care, or they could simultaneously try to improve many aspects of care, right? So there's lots and lots and lots of choices here at the clinical level of what to do. And yet there's always limited resources, right? There's limited staff, there's limited time. You can only do so many things well at once. So these choices of where to allocate time and money and attention are critical. And ideally, the data analyses that we're doing are trying to make that choice as well informed by the data as possible. So with that, I will turn back to our panel.
It is unsharing. So thank you, Chris. Chris is always able to make data interesting. I'm predisposed to thinking data are interesting and fun, but interesting and fun. And I really do want to hear from Kira and but before, I actually have a question for Jess, who has been a senior data analyst. And I think one of the things that feels core to Team Up for me, you know, both in the creation of the model, but also in thinking about the data is how do we field build? How do we push the field? And, you know, Chris, we in research, amongst many other things, have, you know, are built on racist assumptions, including this sort of centering of white non-Latino experience and the sort of grouping everybody together. So Jess, to what degree do you think we can take some of what has been done here and share it with the field, bring it to scale, use it in other areas? Like, can we take some of the things we're learning and thinking about and share them with other folks?
Yeah, and so I think a lot of this actually can be done at scale, especially because really the foundation of this is collaboration and it's discussion working with clinicians and with just teams working with each other to kind of understand their population specific needs. And so we showed the different tables that we had and that we're using. But what really matters from there is kind of like the principles of how that was done, as opposed to doing the table that exact way. So instead of necessarily having something like the exact graphs that we're showing and a guide to how to create those graphs for future health centers, more of information that's very clear and kind of able to be disseminated about really just the processes of that, how you get there and kind of the conversations needed for that, I think are very much able to be done by almost anyone.
Thank you. And to hear, you know, thinking about Brockton, DotHouse, how have you all, use these data? How have they been useful as you thought about your clinical care and clinical model? Either whoever wants to go first.
We haven't really done, like, we haven't made any changes, so to speak. It's been more of like a discussion topic. So Chris sat with us for a long time to talk about this data, and just so you don't feel alone, I'm kind of a data nerd too. So
I'm sure in the audience, we have many who came
so-
in or leaving as data.
So we were talking for a while how one of the thoughts was, like he said, that the screeners might be difficult for a number of reasons, language, or ability to read or anything like that, especially with populations such as Cape Verdean Creole and Haitian Creole. Some of the screeners might be in Portuguese and French, which is the language that they learn in school. However, their native language is actually a Creole, which can make it difficult for them to understand the screeners if they're in, one language or the other. The other thing is that a lot of times when things are translated, they're translated word for word instead of notion to notion. So the idea of something is not the same as the words of something. So I think that there needs to be a lot more research and input from people who are actually from those places and not just people who have studied the language, so that the screeners themselves make sense, they work. There's also this notion that I think we don't do as good a job as we should helping our patients understand why we do screeners. We've had people come in and say, well, I put 3s down the side because I was told if I do that, I get help. I get, I need housing. And if I'm the sicker I am, the more likely I am to get help. And we try to tell them, after the fact, after it's too late, you know what I mean? That the screener wasn't for that. If you need help, tell us you need help. But, they need to understand that the screeners themselves are to diagnose or to help with a diagnosis, not necessarily diagnose, so that they can feel comfortable filling out these truthfully and still have the confidence that we will help them with any other needs they have. So I think those two things, the data, because of the data that we went through with Chris, it kind of showed some populations having outcomes that were a little confusing to us. We were like, how is that? That's not what I would have thought for that population. And then thinking about it more, we're thinking like it could be a language thing. It could be I don't understand why screeners in general. It can also, there's lots of reasons why, like we've talked before about like not wanting to tell our providers or anyone how we're feeling, even in the family, stuff like that. But most of all, I worry about the language thing.
Thank you.
Yeah, I mean, to respond to Chris's earlier question, I'm a firm believer that a rising tide does not lift all ships. In fact, sometimes we do quality improvement work in healthcare and we widen disparities, or we leave a group behind. And, as they say, you can't improve what you don't measure. If we don't look, we won't know. We won't know what the unintended or indirect effects of what we're doing does to patients and families and communities that are underserved. I would just like to praise the wisdom of the Team Up evaluation team for taking the hard route to create a capacity to address some of these questions. I've had the opportunity years ago to work on some data collection projects, and I have to say they went the hard route of creating the relationships, the trust relationships with the health centers and the governance documents and the data submission techniques, and to really allow for us to ask some of the questions that are really hard to ask. And getting this anonymized or de-identified patient level data, so protected in terms of privacy, but detailed and granular enough for us to ask follow-up questions, I think was really wise and difficult. And, kudos to the Smith Family Foundation, the Klarman Family Foundation for financially supporting the capacity building. We often think of like training healthcare professionals and hiring staff, provider staff, but what gets left behind is, building the capacity on the data collection and sharing, and to really make that happen. So because of that, when we get slides or like the one with 10 different graphs on it, the evaluation team, the team up can say to us, okay, look, and Dana and, Alyssa and Nguyen and Julianne and all the other folks, I'm going to miss someone who's sitting here, but from our team at DotHouse, your screening rates are, we don't see any significant differences in screening rates for the different languages of the populations that you serve, but they're also able to answer some of the follow-up questions that we'll have about further downline or downstream process steps, like, positive screeners and, did the patient who had a positive screener get a BH visit? So oftentimes, like in the example of like cancer healthcare quality, we often ask about like screening. So if you ask about racial differences in breast cancer screening, you'll find out that they're pretty good, they're pretty similar across the board. But the real question you want to ask is, what are the health outcomes? And then if you look at mortality from breast cancer, you see pretty clearly that after all these years of work that we've done together in healthcare and in the community, even though there's been tremendous improvement in mortality, it hasn't been shared by all communities. It's very, very clear from the data that our Black African-American women really have not appreciated the improvements in mortality from breast cancer that other groups have. So if we don't ask those questions, if we don't build the capacity to mix up the data, if you will, to ask those questions, it's really hard for us to kind of drill down to what should we do. The question up there, the graph up there that looks at positivity of our screeners, our behavioral health screeners. These are screeners that we ask for patients and parents if their kids have behavioral health symptoms. You'll see the point estimate and the confidence interval for the Vietnamese population is a little lower than the average for the DotHouse population. And you might wonder, okay, or I wondered, is that because the incidence or the prevalence of these problems in our Vietnamese community is lower? Or is it a linguistic issue with the screener where our families aren't understanding, even though it's validated or was validated in a community, that it's not working for our group? Or, are there differences in responses or rates of symptoms for, Vietnamese families where the parents speak Vietnamese, but the kids speak English? Because we don't really ask about the kids' language, we ask about the parents. So those kind of questions, if we wanted to drill down and really understand what's going on, we would have to come back to the evaluation team and say, hey, can you look at this? Is it possible if you look at a smaller group, does the confidence interval go like, whoa, and you can't make any sense of it because now you're looking at such a small group. But I think that's where, the work up front really made a difference. I appreciate the hard work that you've all done and the stick-to-itness, because I know we, like every other provider, can sometimes be difficult with getting data to you. So thank you.
I wouldn't say that. I think it's been a pleasure all the way around. I am mindful of time, so I want to make sure that we are able to take questions for the panel from the audience. So if folks have questions, I think we ask that if you need a mic passed to you, we can do that, or to come down to the mic just so our friends on Zoom are able to hear them.
Perfect. Hi, I'm Schoon Carrington. I am the Director of Integrated Care over at the Mass League of Community Health Centers. So cheering on my health centers always, and also like data nerd as it comes. I'm married to a data scientist and I'm a clinical social worker getting a doctorate in learning Python. So like I'm love data. And my question for you, Chris, so thank you for, 'Showing just sort of like your process. And I think as, we are looking to the future. There's all these predictive analytics, and because I didn't see a lot of social determinants of health stuff. And I think Boyd just mentioned, parental composition, and I'm thinking about people that are unhoused, like when you're really diving in. So what is the role of thinking about predictive analytics, machine learning, and AI, and really using these existing sort of like tools, leveraging them to just make things even significantly easier from the evaluation standpoint? So that's my question for you.
Well, that's an easy one, huh?
Dream big. So
Well, I'll fall back on one of my standard themes, which is it's all about trade-offs. I think that the two big dangers of AI is one is the garbage in, garbage out problem, right? Like the AI can't tell the difference between good data and bad data. And we've seen this with policing data, and predictive analytics and policing do a really good job of figuring out who's been arrested historically, which is turns out there's some racist trends there, right? So like it's a good way of repeating the past. So there's big dangers there, and that relates to the second one, which is the fear I have with AI is that it can shift the balance way toward those of us who love being with our computer and our Python and our little, typing and things that we're not really talking to people about what the data mean, right? So I see this process as a counterbalance to things like AI, but in no means excluding it. I mean, I think ways to automate the process, make it more efficient, ways to look and try to find what are we missing here, right? I mean, I think the strength of what we're doing here is by really harnessing human judgment and perception and that kind of thing. Well, there's inherent weaknesses to that too. Like we could have our own biases that cause us to just miss things. So are there patterns in the data that AI could pull out that ideally we could present back to a group of human beings to try to then make sense of for all these reasons that we're talking about? So I don't know, hopefully that's about the best I could do right now, I think.
Shauna. Yeah.
So your point, don't look. Chris. You sit in your health center. Yes, if you sit on your side, like buckets, do you believe that these REL data will actually be and that hope is there. Is it 10, 15, 20 years out? Then it's really important about it. I don't ask you we have the draft and Dora's box would help us understand how far we are, how well we're moving.
So I would say that it mostly kind of depends on how kind of far along a health center or someone looking into the data is with kind of like an idea. So if there are certain populations to look into from the beginning, it definitely is much easier to find the disparities just because of the prior knowledge of it. And that also will then make it more likely for improvements to be made. For ones that kind of you would find on your own, I think probably would take longer just because there's more discussion on kind of what to do about them. And that gets kind of into the whole conversation of what really is going on. But I think, yeah, it just probably takes a commitment between kind of like all the parties to continue discussing kind of even how we have initial discussions, and then now the evaluation team is going back and making additional analyses based on that feedback. And then also finding places where the current data that we have aren't able to answer certain health centers questions. Yeah, so I think continually kind of working on that should lead to actionable results. Anyone else have thoughts?
I'll throw in, this question was not addressed to me or to Jess, so here we are just jumping in. But I'll say, one thing that's come up is, yeah, there's no reason to have any hope anymore, right? I mean, the world is just a terrible place, but I just can't help myself. And I just am a hopeful person, and teaming up is one of those things. And so it's sometimes it's the unexpected insights when people come together. And if the data can catalyze that, all the better. But just as one concrete example, I walked into this, we created the charts, right? We brought them to the health centers. What are the health centers going to say? I have no idea. One of the things they talked about was the translations of the screeners. It's like, oh, well, that's interesting. We need people who are really bilingual and bicultural, who know a lot about patient care. Who could these people be? Maybe they're community health workers. It turns out the community health workers have lots of opinions about these translations. Well, who's in charge of these translations? Well, maybe I am actually, because I helped create the SWIC and I kind of run that. It turns out that we can improve the translations of these screeners. We really can. And I know that's just one little thing, but it's a connection that I never would have made without these kinds of conversations and without looking at the data and without people sharing their insights. And if we can pick out those low-hanging fruit and help people find their role and find their own meaning, use their own particular strengths to contribute to the larger cause and a larger team, then that's the kind of thing that gives me hope.
Is the thing that this started, which is the table where you categorize the total population to a very simple description, essentially based on see without very much guidance on around what to do if you identify two races. A single category that is multiple reasons, there is a very, very simple way to define how we want to cover population. That table, without editorializing from the Kira like this, will actually narrow cell populations that are going to be impacted. So a very good example of that, South Boston, within their Asian population, has a large. If we do not look at race and ethnicity and language all together and actually deeply, that small population actually doesn't show up. So how do we find, I think part of what I see as a hope and promise is just these health centers being able to be armed with their own data and having had a chance to think about it. So at the point that it gets turned into Mass Health or Mass Health puts something out there, these guys know much more about what that population looks like and how that population is being served. And then that will allow them to have a discussion, hopefully, or how kind of system-wide discussion about data.
Okay, we will turn the last word I was going to say over. We are Kira to one of you.
Yeah, I mean, I have to be optimistic. Maybe that's just because I get to see newborn babies every week. So when you're looking at a baby that's perfect. Yeah, I mean, I think even in the relatively short amount of time that I've been even aware of these conversations, I think we as a community have come much farther in understanding the power of data in improving health for communities. And I think we've become more comfortable with sharing data. And I think to do a lot of the things that that we're talking about, you just have to have the ability to have a critical mass. I think that being said, just like in community participatory or led research, we're on a short leash or timeline as people working in this field or leading in this field to deliver outcomes. I mean, I think it's fair for communities and families to say, look, if I'm going to be sharing something with you I want to see what the good result is for my family, my community. And so I feel the pressure as well to like do something and to and be responsive to the questions that families and communities have, not just my own personal questions. Oh, I wonder what that is. But the questions that some of our community members have that I might not have imagined. Yeah. So I have to be optimistic. I am. I still am.
It's a perfect way to end. Thanks to everyone for joining us. Thanks for